Okay. Well, good afternoon, everyone. I'm Joan Winsenson, the Executive Director of Conquer Myasthenia Gravis. Welcome to this afternoon's webinar, Myasthenia Gravis Subtypes. Next slide. Okay, we'd like to thank our presenting sponsors, our presenting sponsor today, that's Janssen Pharmaceutical Companies of Johnson & Johnson. And we also appreciate the support we've received from argenx. We're grateful for the support of both of these organizations. We'll hear a little bit later from a representative of Janssen too. Please keep in mind that each one of you has a unique health experience. Today's webinar is not a substitute for medical advice. Okay, I'm very excited to bring our presenter to you today. Dr. David Randall is the Director of Neuromuscular Neurology at Advocate Medical Group's Brain and Spine Institute, and that's in Park Ridge, Illinois. Welcome, Dr. Randall. We're delighted to have you here today.
Oh, no, thanks for having me. I'm very happy to be here to try to provide some information for you, and hopefully we'll all learn something more. I'll learn a little bit from you guys, and hopefully you'll learn something from me today. Joan, were you going to go over some of those numbers from the survey before I started?
Yep, sure enough. We asked people a couple of questions just to kind of see where you're at, the audience is at. We asked them about if they knew their MG subtype and if they knew their MG antibody. I was surprised to find out that about half know their MG subtype already, and nearly half know the MG antibody that's triggering their myasthenia. But with that, today, Dr. Randall is going to expand our knowledge of this, and his presentation is about 30-40 minutes. And then next slide. Okay, and after his presentation, Dr. Randall is going to go through a number of the questions that we received in advance from those who are on today's session.
Great. No, and I was impressed both by the number of questions that you guys provided, as well as some of the very thoughtful questions. So at the end, during the presentation, I hope to answer a lot of those questions, or at least pieces of those questions. And at the end, we'll hit some of the others. But obviously, this group's very, very motivated to learn about their disease and what opportunities they have based on their subtype. So we're going to talk about myasthenia gravis subtypes, and I want to talk about the different classification and how that affects your treatment choices. We'll talk about the Myasthenia Gravis Foundation of America classification. We'll talk about antibodies. We'll talk about thymoma status, how age affects choices, and we'll briefly talk about pregnancy as well. All of these affect treatment options. The additional thing for you to keep in mind when you try to write down and figure out what all of these things mean for you is your medication history, what medicines you've been exposed to over time. And when you have all that data, if you go to that doctor or any other doctor, you'll have a lot of good information to start any conversation with a physician about. So I'm going to talk a little bit about just myasthenia in general to get started. This is going to be a review for a lot of you. I mean, most of you or many of you are living with this in different forms. So the initial presentation of myasthenia, and as you know, the hallmark of myasthenia is not a consistent weakness, but a fluctuating and a fatigable weakness with repeated activity. So the vast majority of people, when they initially present, will show up with ptosis or droopy eyelids, and you can see that in the bottom right corner, or double vision, and you can see that in the top on the right over there. So ptosis, droopy eyes, or diplopia, or even some blurry vision are the initial presentation for the majority of people. As we talk further about this, bulbar weakness affects about 10%, and that means brainstem. And those people complain of difficulty with swallowing or chewing or slurred speech. And during the course of illness, it becomes very common, but as presentations about 10% of the time. Less commonly, neck weakness and limb weakness. So mostly in the hips and shoulders, people may present with that as their predominant complaint. And finally, respiratory weakness. Unfortunately, respiratory weakness is a very uncommon presentation for myasthenia gravis, but about 1% or less of the people will present with that as well. So during the course of illness, so during the time that you have myasthenia, about 90% of people will experience at least at some point ptosis, or the droopy eyelids. 80% will experience double vision. And then a majority of the people, 70%, will note either difficulty speaking or swallowing, neck weakness, weakness in the hips or shoulders. And much less frequently, people have difficulty breathing. So that's during the course of having generalized myasthenia, most people experience at least several symptoms. And let me go backwards here. So whenever I make the diagnosis or see a patient I haven't seen before with myasthenia gravis, you don't need to worry about what's on the right side of the slide, but I always want them to get an understanding of their disease process, how it looks to people who are trying to treat them. And on the top, you see the nerve terminal. So that's what's trying to give you the information, trying to say, you want your muscle to contract, so your brain sends information through the spinal cord, through the brain, into the motor nerve, and it gets to the nerve terminal, where it then is supposed to communicate with the muscle fiber. And the muscle fiber is on the bottom part of the page, and you can see how there's receptors directly across from the nerve terminal. There's it's organized so that everything is close together, so that communication through that transmitter or acetylcholine can happen very easily. So the acetylcholine comes out because the nerve terminal was stimulated to make the muscle move. It releases this messenger, or this acetylcholine, goes across the neuromuscular junction. It interacts with the receptors that are directly across from it, and the muscle contracts. And that's how it's supposed to work. In myasthenia gravis, the problem is on the muscle side, so the muscle membrane side. And a couple different things can happen. You can either, well, and both typically do, you get antibodies, so things that block the receptors, so it's more difficult for the acetylcholine to make it to the receptor. And the second thing that happens is the organization, or how they are nicely situated right across from the nerve terminal, they can be disorganized, so they don't match up with the nerve terminal well. And when they don't match up well with the nerve terminal, it's more difficult to get the information, to get the receptors to be stimulated by that messenger. So those are the things that kind of go wrong. So the incidence, meaning how many people per year are newly diagnosed with myasthenia, has been very difficult to pin down to a specific number. It's not a lot of people, probably 5 to 30 per million in a year. And because people with myasthenia typically live many years, the prevalence, or how many people are living with myasthenia, is about 14 to 40 per 100,000. So it's still not a very common disease, but there are a lot of people out there that have myasthenia. And as you know, it's an autoimmune disorder. So your body's immune system is making antibodies directed towards that muscle membrane at the neuromuscular junction. And the most common antibody that's involved in the process is the acetylcholine receptor antibody. It causes impaired transmission with volitional muscles. It doesn't affect the cardiac muscle, so it doesn't affect the heart muscle, and it doesn't affect smooth muscles like in your stomach lining, but it does affect the volitional muscles. And the diagnosis is made, and you've all been through the diagnosis, and through the combination of the symptoms that the patient has, the signs that the doctor finds when they evaluate them, along with the specific antibodies that are found. So most people are evaluated for antibodies. If there are no antibodies, people who are antibody negative ×2, so they don't have the acetylcholine or the muscle-specific kinase antibody, then electrical tests are very helpful in securing the diagnosis. And probably a big chunk of you have been through an EMG test where you do the nerve conductions, the EMG, the needle part, repetitive nerve stimulation to see if there's fatigue. And even some of you have probably been through that single fiber EMG, which looks for jitter, or sort of an instability of the muscle fiber. So what goes wrong with myasthenia? And I want to mention this about the acetylcholine receptor because it's going to be important later, and I'll bring it up again. The complement activation, which is part of the immune system, leads to destruction and simplification of the muscle membrane and the acetylcholine receptors. So complement in acetylcholine receptor positive myasthenia gravis is an important factor. Binding the antibodies to the acetylcholine also blocks the ability for the acetylcholine to reach the nerve, the muscle fiber, to cause a contraction. So, and people ask, well, what about the concentration? If I have a very high level of antibody, or if I have a very low level of antibody, does that make a difference? And the answer is it does not make a difference in the diagnosis. Even if you have a small amount of antibody, you have the diagnosis. If you have a large amount, you have a diagnosis. And they don't correlate well to how severe the disease is. Sometimes we'll use the antibody level in a single person to see if the treatment they've had is effective or if they're getting substantially worse. So sometimes within an individual, you can see if there's variability, and that may be beneficial in treatment, but we don't compare person to person numbers because they don't make a difference. Your friend sitting beside you may have a number that's half or a third of what yours is, and yet their disease is much worse. So the absolute number doesn't matter, but in you, the number does vary a little bit, and it can help guide your treatment, at least to some extent. So characterization. So this is going to be the most of what we're talking about here, is how do you characterize myasthenia gravis? And we're going to look at the clinical criteria. We're going to look if you have a thymoma or not, what your antibody status is, and how your age affects your treatment options. So we're going to start first with the Myasthenia Gravis Foundation of America's classification. And this makes a difference because it tells you kind of where you are in your disease and how aggressive you need to be to treat your disease and what medications are available to you. And this is a very, 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 very busy slide, but it's completely redundant. So there's a couple important points of this slide. If you have class 1, that means the only symptoms and signs that you have are ocular symptoms. So either droopy eyes or double vision and nothing else. No neck weakness, no speech changes, no arm weakness. It has to be isolated to just ocular muscles. And this is ocular myasthenia gravis. Class 1 is ocular myasthenia gravis. Class 2, 3, and 4 are mild, moderate, and severe weakness from generalized myasthenia. So it's weakness beyond the eyes. So you have to have speech or swallowing, neck weakness, shoulder weakness, or hip weakness, in addition or without ocular symptoms. And then you have class 2, 3, or 4. We divide it into A and B. If your principal symptom is the bulbar, so the speaking and swallowing, B for bulbar. If it's axial, meaning your extremities, then it's A. So it's either 2A and B for weakness of speech or swallowing or your arms or legs, that's mild. Class 3 would be moderate. Class 4 would be severe. Class 5 means you require intubation. So you're very, very sick in crisis if you're class 5. So ocular myasthenia, class 1. So ocular, like we just discussed, is just limited to double vision, droopy eyes. And again, 60 or 80% of the initial symptom comes in with that. Most have ocular symptoms during the course of the disease. That slide showed that if you have generalized myasthenia, 80 to 90% of you will have ocular disease at some point. It's defined by the symptoms and signs. You can be antibody positive or antibody negative. Ocular myasthenia only has about a 50% positivity rate for acetylcholine receptor, and there's very few that will have muscle-specific kinase. So half the people with ocular myasthenia will be antibody negative. By 2 years, 15 to 20% will remain ocular, which is great, which means you don't develop generalized myasthenia gravis. And like I mentioned, muscle-specific kinase is rarely ocular. In this pictures show progressive lid drooping or ptosis as this person looks up. So there's medical decisions that you make because it's ocular myasthenia. And we talked about the antibodies, only 50% will have a detectable antibody. If you remain with ocular for 2 years, you'll likely stay ocular, which is great. And the initial treatments are pyridostigmine, and most of you will be familiar with pyridostigmine or Mestinon. And this doesn't affect the immune system. Mestinon or pyridostigmine allows the acetylcholine to stay at the neuromuscular junction longer. It allows the acetylcholine, or that messenger from the nerve, to not be broken down by acetylcholine esterase, an enzyme that breaks up the medication. So pyridostigmine blocks the ability for the body to break it down, so it allows the acetylcholine to be in the neuromuscular junction longer, to have a better chance of causing a muscle contraction. Pyridostigmine is the sole treatment that some people have for their myasthenia, and for the majority, it's part of the treatment regimen. But as you all know, the limitations of using it are often related to the fact that there's a lot of GI symptoms, abdominal cramps, diarrhea, sometimes tolerable, sometimes intolerable. The other initial treatment that's been used in ocular is prednisone. It's been studied well, and it clearly is effective. Azathioprine is also used fairly extensively in ocular myasthenia, but there's not a lot of data to support its use. So we know that prednisone and azathioprine are used frequently. Pyridostigmine is usually the first line of therapy. As we get to the thymus, we'll see that the thymectomy is not indicated for ocular myasthenia gravis. It's not done in these cases, and the benefits don't outweigh the risks. Immunosuppression, either by prednisone or azathioprine, may reduce the rate of conversion to generalized myasthenia if you have ocular myasthenia. So many people will treat people with at least some amount of immunosuppressive medications, even if they have mild symptoms from ocular, in order to try to prevent this potential conversion to generalized myasthenia gravis. And then we go to class 2, 3, and 4. And the difference with class 2, 3, and 4 is that there has to be not only eye involvement, there has to be either extremity involvement at the shoulders or hips or neck, or bulbar involvement, so speech or swallowing difficulty. The treatments for mild generalized myasthenia, which is class 2, is again pyridostigmine, a good symptomatic medicine, doesn't affect the immune system. It has the side effects that are local and frequent, but doesn't have any long-term sequelae. It doesn't cause decrease in your immune system over time. It doesn't cause thinning of your bones. Other treatments for mild myasthenia gravis, generalized myasthenia gravis, corticosteroids, and some form of immune suppression. And that immune suppression can be azathioprine, methotrexate, mycophenolate, cyclosporin, tacrolimus, and more that are coming. So some form of immunosuppression is usually necessary for most, but not all people with mild disease. And people with mild disease are in pretty good shape, functioning very well. So they don't usually have any more aggressive treatment than that. As you go up to class 3 and 4, pyridostigmine, again, a big part of the treatment for everybody. If they tolerate it, it's a good addition. Some people won't tolerate it, so it won't be part of their treatment. Corticosteroids and immune suppressants will also be used, the same variety that could be used for class 2. But for those people with 3 and 4, and these are people with moderate and severe disease, so this is people who you need to treat better. You need to get under their disease under more control. So usually these people are having changes in their immune therapy increased because they're not doing as well. They have moderate or severe disease, which is limiting. So if they fail steroids and 2 immunosuppressive drugs, you fall into that refractory class. And with that failure of these medicines and being moderately symptomatic, other medications become sort of available for treatment or within consideration. Chronic immunoglobulin, IVIG, chronic plasma exchange, which works a little better in muscle-specific kinase. Cyclophosphamide can be used, or more frequently, Rituximab. The newer medicine, Icazilumab, also is effective, but that's only useful because it works in the complement It's only useful in acetylcholine receptor positive patients, the only ones it's been studied in, because it works on that pathway. Rituximab can be used for muscle-specific kinase or acetylcholine receptor positive or antibody negative. And there was a study going back in 2018 for generalized myasthenia gravis that showed sustained improvement after a single cycle, prolonged time to relapse, and reduction in steroid dosage. So that was good evidence back in 2018. Many of you received rituximab even before that, but this was the first essentially best study up to that time to show its benefits. And there's another study that also looked at myasthenia for anti-MuSK patients, because anti-MuSK patients respond less well to a lot of treatments, and it was shown to be effective as well in anti-MuSK population, which was a great thing for this group of patients, and that was back in 2017. It's been subsequently studied as well, and benefits have been consistently seen. And the other one, just again, this isn't really treatment, but Icazolumab, a medicine that came out fairly recently, and a long-acting medication is going to be coming out as well. It showed a change in baseline at 26 weeks in a couple different scales. And the thing that's important to notice is that they looked at 26 weeks. So it does take a while to get the benefits of many of these immune suppressive medicines, and particularly this one. But this was a big study showing benefits for acetylcholine receptor positive myasthenic patients who are either in Myasthenia Gravis Foundation of America 3 or 4 generalized moderate or generalized severe disease. And just to briefly mention crisis, and I think it's important to mention crisis because people who are out there are worried that they're the only one that this has happened to, or the only one that's worried about this happening. And this represents respiratory weakness that's so severe that it may require airway protection or respiratory support. It happens in up to 15-20% of patients, and most typically it happens in the first 3 years. So if you get through your first 3 years, it's much less likely that you would end up having to have respiratory support. And there's other people out there this happened to and they get through it. So it's fairly uncommon, but it's treatable, manageable. And if you have muscle-specific kinase, you have to be a little more cautious or concerned to make sure your disease is well controlled, because about 30% of patients with MuSK will have a myasthenia gravis related respiratory event. So 30%, so it's just something to keep in mind. What do we do for the treatment of crisis? Most of it's supportive. Most people do well. The pyridostigmine's stopped only because it affects secretions and possible cholinergic crisis, which is a very rare event. But those people typically get plasma exchange, IgIV, and then corticosteroids are built up over time, typically at higher doses to control it. So, so you need to know what your clinical status is. So are you ocular? Are you generalized, mild, moderate, severe? So thymoma is the next thing we're going to talk about. It's a little simpler than the class you are in. It's easier to kind of grasp. When you've been diagnosed with myasthenia, everybody should get a CT of their chest or an MRI of their chest to look for a thymoma, because 10 to 20% of people with generalized myasthenia will have a thymoma. So everybody needs a CT or an MRI to make sure. 30% of the patients with thymoma will have myasthenia gravis, but a big chunk of those will have the positive antibodies, but no symptoms. If you have a thymoma, unless you can't have surgery for some reason, it should be removed. For those who can't have surgery because of other illnesses, age, some other issue that prevents it, radiation therapy can be beneficial in controlling the thymoma. But most will have it removed, and there's no debate about that. Little controversy. Where there was controversy for years are people who don't have a thymoma, assumed to have thymic hyperplasia, but no thymoma on imaging. And so finally, after 75 years, 80 years ago, but after 75 years that thymectomies had been performed for non-thymomatous myasthenia, a study proved that it was the right thing to do. So back about 5 years ago, they looked at thymectomy and standardized prednisone versus prednisone alone. And this was looked at by non-surgeons to try to take the bias out. They looked at ages from 18 to 65 years old, and they looked at acetylcholine receptor positive and a generalized myasthenia anywhere from 2 to 4. So it just had to be generalized myasthenia, not in crisis. And they all had to have had myasthenia for less than 5 years. So what they found was it clearly improved the scores for quantitative myasthenia gravis. It lowered the alternate day prednisone that was necessary. Fewer were on azathioprine. There were fewer hospitalizations and fewer symptoms related to immune suppression. So at 3 years, they find very good benefits from having had a thymectomy. Not immediately, but when they looked at 3 years, they saw the benefits. So what times should you have a thymectomy, or at least consider it? Yes, if you have a thymoma, and yes, if you're between 18 and 65, had disease for 5 years or less, and have generalized myasthenia, you should consider a thymectomy. It's an elective procedure, so if you're very ill to start with, you have time to get treated and take care of all of the myasthenia. You may need plasma exchange, you may need IVIG, you may need steroids. But when you're optimally treated, you get thymectomy, and then it reduces over time your exposure to immunosuppressant therapy, which is a great thing. And then there's the maybes. So they didn't look at people over 65. They didn't look at people less than 18. And the people over 65, you have to live well for at least 3 years to have benefit. So you have to wonder about patients' general health. And under 18, there's more spontaneous remissions. So it's hard to know exactly which ones need to be done. A longer disease course, more than 5 years, it's unclear if the thymectomy would be of benefit or as much benefit. And if you're acetylcholine receptor negative, then it's unclear, but it may be of benefit. I have had people in all of those categories go through thymectomy in my clinic for one reason or another. The people who aren't candidates for thymectomy are pure ocular myasthenia. So if you have only ptosis and droopy eyes, there's no data to suggest that it prevents generalization or improves chances of remission. Muscle-specific kinase positive patients have pathology that's not related to the thymus, so it's probably not a great option, or wouldn't expect good relief. The same with LRP4. And because if you're Myasthenia Gravis Foundation 5, you're in crisis, it doesn't work quickly. It's not the right thing to do at that time. It takes up to 3 years to see the benefits. And pregnancy is obviously the wrong time to go through a thymectomy because it's not an emergent procedure and it doesn't give you improvement right away. So your thymectomy status is the second big course. The next one is antibody status, and I was fascinated to see that less than half of the people know what their antibody status is. And I would challenge you all to make sure next time you see your doctor, you find out what antibodies have been tested for and which ones you have that are positive, and have that as part of your known medical information. So let's talk about a few of those. So acetylcholine receptor antibodies, we've talked about those a little bit already. Those are the most common that you'll see. The binding antibodies are the ones that we talk about principally because they're very sensitive and specific for myasthenia gravis. There are a few false positives. People with family history can have acetylcholine receptor antibodies and not have disease. Some people with thymoma can have positive antibodies but no disease. And rheumatoid arthritis, among other things, can have antibodies but not actually have myasthenia gravis. But in general, it's very sensitive and specific. The blocking antibodies are not so sensitive or specific, and the modulating antibodies are not sensitive at all. There's a lot of different conditions where you can see those antibodies positive and not truly be associated with myasthenia gravis. So acetylcholine receptor antibodies, we're typically talking about the binding antibodies. For the MuSK antibodies, so the kind of the second big exciting antibody after acetylcholine was this muscle-specific kinase. And unlike directly blocking the antibody, as can be seen partly with the acetylcholine receptor antibody, this impairs how those receptors are organized across from the neuromuscular junction, from the nerve. It's present up to 8% of patients' myasthenia, more common in Mediterranean than Northern European patients with myasthenia, and it's not related to complement, which is important to know because there's several medicines that are coming out that are complement mediated. So they wouldn't be expected to help in muscle-specific kinase. Acetylcholine is one of them that's currently out. It also reduces this post-synaptic density and impairs the localization. The great thing about MuSK and following disease is that the levels do seem to correlate very well with the severity of the disease. So when you're treating somebody, you're seeing how sick they are. The amount of the antibody they have is informative. So certainly worth doing. And in people with MuSK, I tend to follow their levels much more closely, not frequently, but more closely than if they had acetylcholine receptor. LRP4 works very similarly to the anti-MuSK by inhibiting the normal mechanism to maintain and organize the neuromuscular junction. In MuSK, there's more respiratory involvement, and that leads to why there's more episodes of crisis. It's a slightly worse prognosis, more difficult to treat. The great news is its response to Rituximab, less responsive to pyridostigmine, and the thymectomy is not expected to give you a benefit if you have muscle-specific kinase. LRP4, I'm very excited about LRP4 because we still don't know that much about it. We're learning more. And as we move forward, now that it's easier to test, we're going to learn a lot more about it and how we should treat patients who have LRP4. Similar to MuSK, it impairs the organization. 1 to 5% of patients with myasthenia gravis, but interestingly, of the patients that don't have the acetylcholine or the MuSK antibodies, 7 to 33%, so up to a third of them will have this antibody. And this is similar to the acetylcholine receptor antibodies. If you move it from one person or one mouse to another mouse, you can transfer disease. So it is pathogenic. Fortunately, milder disease, mild generalized and ocular myasthenia, milder symptoms at onset and typically throughout the entire course of the disease. It is not associated with thymoma. Rarely will get into crisis. But if you have the other antibodies as well as LRP4, so if you have an overlap of those antibodies, they tend to do worse, more similar to how they would do with the acetylcholine or MuSK antibody. It is not fully specific. It can be seen in other autoimmune diseases, including or other autoimmune diseases, as well as ALS or Lou Gehrig's disease, amyotrophic lateral sclerosis. I think the verdict is still out. We still don't have all of the information about LRP4, and we should know a lot more in the next 2 or 3 years. So then there's others, and I'm just going to mention these briefly. These aren't routinely even looked for. The top 3 have been seen in the disease, and they're much more common to be seen when somebody has myasthenia than if they don't, and that makes them more important. Agrin, again, affects that clustering. It's part of that MuSK and complex, LRP4 complex, and they can see antibodies to that as well. There's no direct pathogenic effect, so you can't move the disease to something else by taking those antibodies. The Titin antibodies are important because there's a much higher association with thymoma, and it tends to affect the late onset people. Ranitidine is associated with severe myasthenia, and so it can be interesting in that sense, but the majority will have thymoma and more severe disease. The collagen Q antibodies and caractin antibodies are interesting, but they're also frequent in normal controls, so it's hard to know how pathogenic or how important they're going to be, but that is being looked at. None of these antibodies are routinely done, but some people do get this information as well. So those are the antibodies. As for age, I used to think less than 50 was definitely young and over 50 was definitely old. I'm starting to rethink that whole process of is less than 50 young or old, but it makes a difference in myasthenia. So early onset acetylcholine receptor positive myasthenia, less than 50 years old, are much more likely to have a remission. Early onset below 50 is female predominant, and they usually have thymic hyperplasia. And most of them are good candidates, if it's generalized, are good candidates for thymectomy. The later onset or beyond 50 years old are less likely to have a spontaneous remission. There's a higher rate of thymoma in people over 50 years old. There's a male predominance. And if they're over 50 years old, if they have a thymoma, certainly they need surgery. If they don't have a thymoma, they still may be a candidate for thymectomy up to 65. And if they're healthy, maybe even beyond. But younger than 50, definitely a candidate for thymectomy, younger than 65 even. And I'm gonna just briefly talk about pregnancy here. The real key for pregnancy is to plan, prepare, because you don't wanna be on immunosuppressant medications that are of high risk to the fetus, and you wanna make sure your disease is under good control going into pregnancy, as pregnancy can affect how you feel with your myasthenia and how weak you are. So plan. First line therapies, Paracetamine orally and Prednisone are safe and effective during pregnancy. Second line medicines, azathioprine and cyclosporin, kind of less known during pregnancy and more potential risk. And then high risk medicines would be mycophenolate and methotrexate. So you have to try to avoid those during pregnancy. If there is an exacerbation, you can treat it with IVIG or plasma exchange safely. And magnesium is sometimes used during pregnancy. It's a good medicine to avoid in myasthenia in general, as some people feel weak when they take magnesium. And the newborns from somebody who's had a baby or who has myasthenia, has a baby, you can passively transfer these antibodies to the baby. So the baby may be weak in sucking, chewing, swallowing, holding its head up for several days or even up to a week or so because of these transient myasthenic antibodies. So you have to watch for transient neonatal myasthenia if you have a pregnancy. The fortunate thing is that resolves very quickly and you just need supportive care. So my conclusion from all of this is that myasthenia gravis subtypes do determine your treatment options. And no matter what you have, there's treatment options, fortunately. But knowing your subtype will allow you to have a better understanding of what those options would be, and maybe why you were or weren't offered certain options. So I challenge you guys to kind of put down on a piece of paper or carry it with you or put it on your computer, your phone, several things. One of them is the age of onset you were when you developed your myasthenia and the years that you've had the disease. The second thing to put down is what's your antibody status, because this also affects the medicines that you're going to expect to have benefit from. Do you have acetylcholine receptor antibody? Do you have muscle-specific kinase? And do you have LRP4 or low-density lipoprotein receptor-related protein 4? So you should find out if you're positive or negative to all of those, and your doctor probably knows if you don't. Then you should talk to your doctor about what's your class. Do you have just ocular myasthenia, and have you had it for 2 years? So could you expect that you're never going to develop generalized myasthenia? Do you have mild disease? So you're probably not making big changes in the treatment is the right thing for you. Or are you struggling with moderate or severe disease and you should be looking at other options? So those are the things you should try to keep in mind from what your Myasthenia Foundation classification is. The next thing you want to know is, you had your CT. Do you have a thymoma? Yes or no? If you had it, you probably need to have surgery. Have you had a thymectomy with or without a thymoma? If so, when did you have it? Because your treating physician, if you had it a year ago, will say, maybe we don't need to be as aggressive in 2 years. We'll see how much benefit you have from your thymectomy. Or if it's been 10 years and you had no benefit, there's probably no more benefit to be expected at that point. And then pregnancy, plan pregnancy. And what I should have written down for number 6, was medications you've been exposed to. So what medicines you've been on and how you did. If you didn't tolerate it and you're off of it, or if it didn't help you and you're off of it. So the medicine you're on and dosage. So that was the other thing that I think what you need to know, what to know about your myasthenia to try to help you and help your doctor get you the best treatment available. All right, so questions. So Joan, do you want me to pause here, or do you want me to go right through some of these questions?
I think, why don't you go ahead with these questions? We know this audience already is these are of interest. So start with that, and then if anybody wants to type in a question now, feel free to, and I'll feed those to you after you go through these.
Okay, so some of these are going to be a little redundant. Like I said, you guys had great questions. I hope I covered some of them as we went through. But how do you find out the antibody for my myasthenia gravis? So that's simple. So there's blood tests available, lots of different labs do them now for all three of the ones that I think are important to know: for the acetylcholine receptor antibody, for the muscle-specific kinase, and for the LRP4. As for the course of treatment, again, most people, depending on where you are with how sick you are, if you have just ocular disease or if you have generalized disease, what age you are is all going to make that determination. So how is this decided is based on what antibody you have, how old you are, and do you have a thymoma. So all of those things we've talked about will feed into what the best treatment course for you is. The next good question was, how do we find out our subtype? And we've talked about that. Do all people with the same subtype have the same symptoms and progression through myasthenia? And it's a great question. The answer is no. I mean, even in individuals, as you've all experienced, it's a very variable disease. So people, even the same person, varies a lot week to week, month to month, potentially year to year. So people vary a lot. So it's hard to know just because somebody has the acetylcholine receptor antibody and they have generalized myasthenia, they may need 3 or 4 immunosuppressants in order to keep them under control, or they might just be on Prednisone. So everybody's different, and you have to find the right regimen for you that you tolerate and is effective and keeps you down to that mild disease, hopefully. And then there was a specific question: what's the best treatment for generalized, late onset, seronegative myasthenia? So generalized myasthenia requires across the board trial of pyridostigmine. Prednisone at low doses is usually the first treatment, and then other immunosuppressive medications in order to get the person to that level of being mild disease to remission. Just because you're seronegative doesn't mean you can't have as severe disease as anybody else does with any of the antibodies. But being seronegative, the effects of a thymectomy are more in question. If late onset is 80 years old versus 60 years old, if you're 60 years old, you might still be a reasonable candidate for thymectomy, but because you're seronegative, may not be the best option for you. If you're 85 years old and seronegative, you're probably not going to be a very good candidate for thymectomy. So usually immune suppressant medications starting, or pyridostigmine plus some variety of immunosuppressing medications. Solaris or Rituximab is not a good option for seronegative. Okay, next question was prognosis with ocular myasthenia gravis to progress to generalized with onset in the 80s. We don't really change the numbers as people go into their 60s, 70s, 80s, 30s, 40s. If you have stayed with your ocular symptoms isolated for 2 years, it's unlikely that you're going to get going to generalized myasthenia gravis. So it's about 10 or 15% of people will stay as ocular myasthenia. Mild disease in the 80s is sometimes very easy to treat as well. So that's the good news. The next question: how long is the average stay in remission? I have had anti-MuSK version of myasthenia, and after being treated with Rituximab, I'm in remission. So that's great news that you're in remission. It doesn't bring everybody into remission. It is a good drug for MuSK myasthenia. People tend to stay in remission for 6 months to a year, but some people stay in remission forever. There's not enough data on how long, but remissions can be fairly prolonged. And recurrence, you can retreat with Rituximab with again, good results. So I think people who have such a good response, like end up in remission for a period of time, it's a very good sign that they'll either stay in remission or be easily treated to remain near remission or in remission intermittently. All right. What possible antibodies might cause seronegative myasthenia? So if it's seronegative, we usually now talk about as being negative for both acetylcholine and muscle-specific kinase. So LRP4 is another one that I think is important. But those other antibodies I showed, the Titan, are also ones that may cause it. As we continue to look and the science evolves, we may find more important antibodies. So we're not done yet. Well, they'll still be looking. Again, my blood panel came out negative. Am I seronegative? As long as you've been negative to both acetylcholine receptor and MuSK, you are seronegative. But the treatments, again, there's still treatments, and the disease can be still as troublesome, even seronegative. Okay. Why have the medications I've been prescribed not helped? And this is one of those challenges with a lot of autoimmune diseases. People don't necessarily respond to medications that are tried, and that's why people end up on a variety of different medications to find the right medication for the right person. Some people are more resistant to treatment and need to increase. So people who have failed a couple different medicines may end up on IVIG or plasma exchange, or candidates for Rituximab or cyclophosphamide. So there are options all through the disease course, and hopefully you can find one that will be more beneficial and you'll tolerate. Is there hope for new treatment? I'm going to go a couple slides ahead for this, and the answer is conclusively yes. There is hope for new treatments. There's a lot of new treatments coming soon. There's a lot of excitement about additional complement inhibitors like Acetylcholine that will be coming out. The FC receptor inhibitors are also a class that looks like it's very promising. B-cell depleting agents and stem cell transplants are also things that are in the pipeline and been looking at much more seriously than they have before. So there will be a variety of drugs that are coming out in the next year or two that will change the course of treatment for several patients, and hopefully more tolerable immunosuppressants. The complement inhibitors, the FC receptors inhibitors are all supposed to be drugs that are kind of better tolerated, but we'll see how that plays out as they become available for use and see how effective they are. The exact drugs are kind of beyond the scope of this talk. The other one I want to talk about, there's a non-immune treatment that's coming out that's sort of it's a way to use Mestinon, but it's not Mestinon, but it helps work at the acetylcholinesterase. So that will be great if it works, because hopefully all those side effects, those GI side effects, can be eliminated, but still get the benefit of the Mestinon, the Paracetamine, to have more of the receptor at the neuromuscular junction. So pretty excited about that. Oh, and then this is a question I get every summer. Heat and humidity bring on my symptoms, fatigue. Is there anything I can do besides moving to a cool temperature desert? And the answer is it's difficult. But what I recommend that people do is that they plan their day. So with myasthenia, it's a chronic disease. You need to try to make the best quality of your life for you. So how long do you need to be outside? What are the things you want to do outside? If it's going to be a very hot day, can you do it a different day? Can you limit your time there? Can you prepare to have your fluids and everything else ready? It's really a matter of planning and limiting on those very bad days. Some people are much more sensitive than others to heat and humidity, but it's a very common complaint. And again, I say kind of pick what's most important for you to do and do that. People come back and say, but I want to go to a Cubs game or a White Sox game. And I don't know if it's going to be hot or not outside. And I see how that can be very, very difficult. So, but if you kind of plan your time the best you can, limit your exposure if you're very sensitive, and enjoy the most important things to be outside for, is always my advice. And the final question I thought was interesting was, am I hurting myself by not taking Mestinon regularly? I have ocular and generalized myasthenia gravis. Mestinon makes me sick. So this is somebody who has generalized myasthenia, because if you have ocular symptoms and generalized symptoms, you by definition have generalized myasthenia. And Mestinon doesn't affect the immune system. There's no very long acting effect that it has. It is symptomatic treatment, so it just makes you feel better and stronger at the time. So there's no downside in not taking it affecting your disease long term, because it has no effect on the disease itself. It just makes you feel stronger at the time. So you're not hurting yourself at all And there are people who absolutely cannot tolerate pyridostigmine. It's too tough on their stomach. We usually try for those people. Some people try Imodium with some help. We use a lot of glycopyrrolate that can help some of the side effects because it's terrible to feel nauseous or have abdominal cramps or uncontrolled diarrhea. Those medicines can sometimes help people, make them tolerate the medicine better, in which case you can use a Mestinon, which can be a very effective drug, but you are absolutely not hurting yourself by not using it, just you'll be potentially more symptomatic.
Okay, great information. I've got a couple more questions that I'll pass along.
Sure.
I'll start with one for myself. Could you explain the word hyperplasia?
Hyperplasia, sure. Hyperplasia just means an overgrowth or too many of the cell. So it's so people have hyperplasia in the thymus. It's just there's more tissue than expected, but it's normal tissue, not tumor tissue, just normal tissue. And people have thymic abnormalities sometimes have this record as hyperplasia or too many cells, but not pathologic at all.
Okay. Here's one more question from me. Complement. Here's how I'm understanding things, and correct me. Okay. Okay. So it sounds like there's a bunch of different proteins sitting on the muscle, and they're called complement, and they cascade where they there's a reaction with one that affects the next, and then the next, and then a complement inhibitor is one that interrupts that
right.
cascade.
Sure. So complements are part of the immune system. They're not part of they're part of the immune system, and they kind of up the regulation of the immune system. So they make the immune system more active. And complement inhibitors and complements happen very early in the course of the immune system. So the complement inhibitors try to stop that sort of overreaction of the immune system. So that's how complements play a role. They're early in the immune system, and by controlling them, you get less of a big immune response.
Okay, super. I'll move on. Okay, are there new treatments coming out for MuSK-positive MG?
So that's a great question, and there are, but most of the treatments have been focused on the acetylcholine receptor positive type of myasthenia. So all the complement ones are all going to be associated with that. There will be, or some of those medicines, the B cell depleters and things will affect MuSK as well. So there's opportunities for better treatments for muscle-specific kinase as well.
Okay. Could convalescent plasma given for COVID-10, I'm seeing, but maybe that means COVID-19 pneumonia treatment, have provided LPR4 antibodies?
So give me the question again, I'm sorry.
Sure. Could convalescent plasma given for COVID-19 pneumonia treatment have provided LPR4 antibodies?
Yeah, so that I'm not sure. I don't know how they, I mean, that was in the acute treatment of people they were doing those infusions. I don't know if there was any ability to transfer. I'm not sure that's a transferable one through that process or not. Most of those processes, they limit a lot of the proteins that cross, but I can't speak for that.
Okay. Let's see. I'm 62, have ocular MG for 4 years, currently on 1 to 2 Mestinon per day and IVIG monthly. Does this sound like the best treatment regimen? And I think it's fair for you to say whether or not comfortable even answering that.
So usually IVIG is not often used for isolated ocular myasthenia. So it would be a fairly aggressive treatment regimen. I don't know how bad the symptoms were that made the person decide. So everybody's different. It's certainly not part of the typical treatment plan for ocular myasthenia.
Okay. This person says she's very worried about Rituximab side effects. Read about a very serious one. Her doctor wants to have this med. Could you comment on that?
Yeah, so there is Rituximab does have a warning that it can cause PML. So there's a big infection you can get associated with Rituximab. the neurologists are usually that's why you want to make sure somebody's failed other things and are still very symptomatic before you choose that. So it's sort of a decision based on how sick you are, quality of life, what's most important for you. The rheumatologists who've been using and the oncologists who've been using rituximab for years are very, very comfortable with it. Neurologists have been using it less than they have for a long time. It looks like it's been pretty safe in the myasthenic population. The doses are typically a little lower than they are for some of the other disease things, but there is some risk. So you have to kind of weigh what you're willing to take for a risk for medicine. But the truth is, of all of our medicines, there's always going to be a risk-benefit ratio about what's the best treatment for you. IVIG, they can have blood clots. You can have cardiac dysrhythmias with plasma exchange. There's not any of our treatments done against the immune system that don't carry at least some risk. So I think you need to have a very frank discussion with your neurologist and say, I'm worried about this for this reason. Why is this the best treatment for me? And I can tell you, people with moderate disease that you can't get under better control and it's affecting their quality of life, we do use this medicine, and it has proven to be effective for a lot of people.
Great. One more question, and then we'll bring in our Joe Flutie from Janssen. This question is time-released Mestinon less likely to cause cramps?
Yeah, so the answer is it probably causes less cramps, but in general it's less effective. The absorption of the time span has been very difficult for people. So you never know exactly what you're getting with the time span. From an absorption standpoint, it's just not as you just don't get as much. So some people like time span. The vast majority of people prefer the short acting because it's so much more effective. Some people who take it overnight, but if you can't tolerate the short acting and you've tried other things like a Purolate and the Imodium, it certainly is another option. So you don't want to knock any option off the table.
Okay, well, thank you very much for those questions. I think we'll close now and we'll move on to the next slide, if that's possible. Great. And welcome, let's see, we'll wait for your slides so you have there you go. Okay. Joe Flutie, welcome today. We're glad to see you and glad to have you here. Joe is from our presenting sponsor, Janssen, and Joe is Janssen's Global Director for Commercial Strategy. So welcome today.
I appreciate that very much. So to Joan and the entire team at Conquer Myasthenia Gravis, thank you for having me. Dr. Randall, as someone who's new to the space, I took copious notes, so this was very, very appreciative of that as well, following you. So thank you all so much. So as you mentioned, I come from Janssen, and Janssen is actually the pharmaceutical arm of Johnson & Johnson. And so we are very excited to build on the momentum that Momenta created in this space, and to do as much work as we can in serving the patients and their families that have myasthenia gravis. So our first responsibility, my first responsibility, is truly to get to know all of you, get to know your stories, get to know your wants and your needs, so that we as a company and organization can do everything that we can to help and support you. Right now, the best way for you to interact with us and for us to learn from you would be to visit a website that we call imaginemymg.com. It's an opportunity, as I said, for you to learn about some of the things that we're doing. And more importantly, it's an opportunity for us to hear directly from you, your stories, see your pictures, learn exactly what it is that living with myasthenia gravis is like from a day-to-day perspective. And I can tell you that there's a lot happening at Janssen, especially in this area. The website is up and running, but it's going to get a whole new overhaul in the next couple of weeks. But for right now, that is absolutely the best place. And then obviously, if you'd like to learn more about Johnson & Johnson, you can just go to jnj.com, and we have a wealth of resources and information for you there. But I will digress. It's again an honor to be here. I'm humbled to serve in this space, and whatever we can do, we're absolutely here for you, and we look forward to serving you. Thank you.
Thanks, Joe. Thanks very much. Okay, next slide. There we go. And that's it for today. Dramatic slide. I want to thank Dr. Randall so much for the time and information and knowledge that you've shared with us. It's great. Thank Joe for joining us and sharing. We appreciate Janssen's interest in myasthenia gravis and certainly the work they're doing in that arena as well. And thanks to everybody who's joined us as a participant, as an audience member. Thanks for your questions and your interest with this. Next slide. If you appreciated this information, please know that we would appreciate your support. And next slide. And last closing thing, if you would like more information about myasthenia gravis, please visit us at our website, which is www.myasthenia.org. Thanks very much, everybody.